Call this meeting to order. It is now 6 o'clock on Wednesday, September 8th, 2021. We will begin with the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Now, a reading of a mission statement. Is there a board member that would like to read the mission statement?
Sure.
Glory?
Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence.
Thank you. Before we adopt the agenda, I'd like to have a moment of silence. As many of you know, Phil Kraft's mother passed away, Pamela Kraft. She passed away suddenly and unexpectedly after a short illness this past Sunday, and so I ask everyone to have a short moment of silence. Thank you. Adoption of the agenda.
Support.
Motion by Lori, support by Megan. All in favor signify by saying aye.
Aye.
Motion carries. Request to approve. That's right. Hearing of the public. Now is the time to address this board. If there's anyone from the public looking to speak. Is there anyone from the public looking to address this board? Going once, going twice? Request to approve Nexecute contract. A motion by Linda, support by Antoinette.
So I can speak to this one. So this is the request for the consulting services with Chris Elias. He's the consultant who helped us through our first year of strategic planning. He also provides some coaching services under this contract for the executive team, so for Dave, for any of us. I personally, reach out to him every month or so to discuss some coaching items. In our first year of strategic planning, which just ended, we had 5 annual initiatives, which I'm going to talk about a little bit later. 3 of those were completed and 2 of those were continued, so we did see some successes throughout the first year of our strategic plan. And if the upcoming year is approved, then we will have continued quarterlies with Chris involved, as well as the annual, which will be next either August or September. So happy to answer any questions on this one.
And no questions? All in favor signify by saying aye.
Aye.
All opposed? Motion passes. Request to approve MyCare Health Center staffing contract. Is this also you, Adam?
This is actually Agnes.
Agnes. We would need a motion, yep.
Support.
Motion by Linda, support by Antoinette.
Good evening. So this is a clinical position. It is a shared position between MyCare, our FQHC, and CMH. This clinician is actually currently has been in her role for 2 years. This would be an update to the contract. She works up to 15 hours per week at MyCare, and then she also works for us as well, the other half of the time. And she is truly in that integrated care role where she will link our individuals served to MyCare services from CMH. And what she'll do is she also links the individuals from MyCare seeking medical care and medical treatment to behavioral services through our agencies. So it's truly kind of that dual role where she's linking people to either behavioral or medical services.
Nick?
Yeah, thank you. I think this is an excellent program. I just have a couple of technical questions on the content. It's the HRSA 330 grant that funds this. What does HRSA stand for?
I want to say this is probably something that this actually happened before my time, and it's something on the MyCare side based on their grant funding.
Well, oh, okay, because it indicates they have to notify us of any changes in the grant status, so that makes sense. And then I noted that in one provision in the contract, there's a provision that requires us to comply with MyCare policies, but there's no comparable provision the other way around. Is that in their contract that they have to comply with ours?
Yes, so actually, this is our ABO employee who shares her time, so they're automatically complying by all of our policies.
Well, it specifically requires that she comply with our policies in the contract, but there's no indication that, is she, her regular employment's with the other, with MyCare?
Yes.
So she obviously would be
Yes,
bound by their policies. as well.
absolutely. Yes, so she does comply with their policies as well. It's an expectation of her work as well.
Yeah, I think this is an excellent program because it's helping us to assure that people's physical and behavioral health are both dealt with
Yep.
and coordinated as well as possible. So I'm really happy with what's been going on there.
Thank you, we are too.
Any other questions or comments? Hearing none, all in favor signify by saying aye. Aye. Motion carries.
Thank you.
The next item is the request to approve the travel to attendance of the compliance academies for 2 CMH staff.
So moved. Support.
Motion by Megan, support by Donna.
And this will be, Stacy will be able to talk on this.
Good evening. This board had previously approved for myself to travel to receive my compliance certification. As a result of COVID, that was canceled, and so they had given me a credit for the conference to attend the conference. At this point in time, they haven't rescheduled additional compliance academies similar to the one I had been approved to attend, except for 2 weeks ago in New Orleans, so I'm glad I kind of missed that. But they allowed me to transfer those monies for Madison to attend a Healthcare Compliance Association Academy. We looked to see which one was cheapest, and it turns out Las Vegas is the cheapest of all of them. It was DC, San Francisco, Las Vegas, and Las Vegas had the cheapest. So with transferring over my credit for my Compliance Academy and her lodging and her flight and the exam, as well as the membership fee, we're still saving the $3,250 that was still a credit, but it will expire in April, and they're not reoffering my conference. So for right now, I'm just asking for Madison to be able to attend the conference and to get certified in November.
Any questions? I have one. What's the benefit for certification after passing the exam?
So she'll be able to continue CEUs. Hers was Healthcare Compliance Association. They provide a lot of ongoing education. A lot of it's offered free, which is amazing. They didn't used to do that. They also provide additional training on how to conduct a compliance investigation, things of that nature that would be consistent with what the OIG technical assistants should be providing us, that they are not to date. I can give her all of my resources and education, but to have her gain additional knowledge, I think would be a true benefit to Macomb County. It will also increase her network, that she can reach out to other compliance officers in other healthcare fields to find out what they're doing, and also she will be updated more frequently with regard to changing in legislation and things of that nature that could impact Macomb County.
And so do we get periodic updates from this group? And the CEUs, you mentioned that it opens us up for additional continuing education as well?
It does for her. So
For her.
after she becomes certified, she'll be required in a 2-year period to get 24 CEUs. She can get probably 20 of those if she goes to their annual conference within that 2-year period, but otherwise she can do a lot of the online training that they provide. She can also, they put out a great magazine. I mean, it's not a thriller to most people to read about compliance, but I actually like it. But she could read the magazine and take the quizzes, and she's already started doing that anyway because I get the magazines. But it, again, keeps her knowledge very, very, very fresh. We don't have to wait for the state to push out compliance information. She's going to get straight from other resources.
Thank you. I saw the program. I love that it started with the basics and then it went to advanced, and, you know, it's so important to get the basics right, too, and just always refreshers and advanced and updates, so.
And HCCA is very healthcare-based, whereas SCCE, the Society for Corporate Compliance and Ethics, is the certification that I was seeking as an ongoing. I've already done the HCCA. It's a great marriage and a great mix.
Awesome. Thank you. Any other questions? Nick?
Yeah, I'm sorry, did I misunderstand you? The request is for 2 staff? Are
It
you-
was going to be for 2 right now because they allowed me to transfer my credit to Madison, and they're not offering one for SCCE. I'm just asking for it for one person.
So you're amending this request to
To one person.
authorize just the one?
Correct.
Okay, thank you. I just want to be clear.
Looking to see what the motion was to approve. Yeah, the motion, I think, was 2. Do you want to amend your motion?
I move to amend my motion to 1 staff member as opposed to 2.
Okay. Is there a second? Okay. All in favor signify by saying aye.
Aye.
Aye. All opposed? Motion carries. Thank you. The next item on the agenda is the Afia contract. Is that you, Adam?
That's me.
Okay, the motion's in order? Motion by Selena and support by Lori.
So this is to renew our contract with Afia. As you may remember, Afia is our data warehouse as well as our dashboard and reporting system that we've been working with. We also have a technology grant, the same as we did last year, which covers the majority of this contract. Our reporting contract this year will cover a few things: report writing, which would be creation of new dashboards by Afia, training. You also may notice that we have reduced hours for Afia this year, and part of the reason is the plan has always been to move this in-house. And we did hire Rachel, who is our Director of Clinical Informatics, and through the training that they're going to provide, we're moving that reporting piece more in-house as opposed to putting those hours with Afia. So that's the reason for the reduced hours and some of the reason for the training. We also have some CCBHC consultation, which we'll continue to use them for. They've got some staff who have experience with CCBHC, so we've been using them with help on workflows. And then just the project coordination, both with our direct staff and with some of the technical staff on the report writing. So that's basically what it's going to cover for this year. Nick?
Yeah, we were getting, let me ask it this way, both as to the net exec and the Afia, when will we next be getting a report on the results and the benefits
The results from Afia, or?
from the administration to us, because they're the ones working with them in terms of what benefits and what the results have been of these 2 contracts?
That's a good question. I could probably get something together by next month, if that's okay.
Well, I'm not anxious. I understand these contracts, but I think we're supposed to periodically get a report from the administration, so it's just a reminder.
Okay.
As that I would like to see it.
Yeah, I will prepare something, and it'll show just some of the recent updates that we've been able to make in it, and then some of the future plans for it.
Thank you.
Any other questions or comments? Hearing none, all in favor signify by saying aye. Aye. All opposed? Motion passes. The next item on the agenda is the request to approve the Third Amendment for the Substance Use and Prevention and Treatment Block Grant for 2021. That's Amendment 3.
This is Helen. She's coming up right now.
Motion by Linda, support by Antoinette.
Hi, good
Hi,
evening.
Ellen.
I'm back again with another amendment for our e-grams, so you'll get to see me quite frequently because we've got more, I'm sure that'll come. So this one now is still for the current fiscal year. So the state was able to award us some additional money for room and board costs at residential treatment programs. That's referred to the State Disability Assistance Funds, SDA. And so it's a funding type that they have. They disperse statewide based on kind of historical patterns. But what'll happen is if there's a region not using all their money, the state gets a report before the end of the year, and then they look to see if there's other regions that can use it up, because it's not carry forward money. So you have to use it in the year that it's awarded. So we have plenty of need for this money. So they gave us an allocation of $42,430. We get about $87,000 to begin with, so about a 50% increase. And it just covers the cost of room and board at residential treatment, because we can use Medicaid dollars and block grant dollars to pay for the treatment cost. But on Medicaid, we're prohibited from paying room and board with Medicaid dollars. So we have to have another fund source. And this is one of the fund sources we use. We also use what we can't cover under SDA, we use our block grant dollars for. So, extra money.
Selena?
I am going to abstain from voting because my organization has a residential program.
Okay. Any other comments, questions? All in favor signify by saying aye.
Aye.
All opposed? Motion passes. Thank you,
you.
Helen. And the next item on the agenda is to receive and file. Is there to receive and file anything? Resolutions? I don't see any resolutions. Presentation, Live Right Corps.
I do the same thing.
And we're live, too. I'm Brenda Max with Live Right, and we're going to pass out some of our presentations so that you can see them and follow along as well. Probably should have done this to begin with.
Oh, thank you.
Oh, thank you.
This just has some, the brochures for the rest of the information at the resource center, but our presentation is primarily focused on our assisted outpatient treatment.
Thank you. Thank you.
Yeah.
This is Charles.
For sure.
Mark already knows about us. Do we have an extra one? I'm good? Well, thank you for having us.
Short?
Yes, we're short.
Oh.
Okay. We have a couple up here that need them.
This one.
Oh, thank you. Is there anyone else?
Right over here, Lisa.
Oh, thank you.
She needs one. Sorry about that. So we're here to talk about our new program. It's AOT, Assisted Outpatient Treatment Supportive Services. So this is a grant, a SAMHSA grant that we received at the end of May, and it's no cost to the participants. It requires an active AOT order that shows their impaired understanding of the need for treatment, continue to be non-compliant with recommended treatments, and are necessary to prevent relapse or harmful deterioration of their condition, demonstrate a history of non-compliance, including 2 hospitalizations in the past 36 months, acts, threats, or attempts of violence to themselves or others. Our program goals is to provide evidence-based wraparound services using non-clinical peer-to-peer approach. So we have one-on-one services. with an individual. There is peer recovery coaches, we have a wellness instructor, coordinator, we have a family coach that can also help their families. We have a case manager, RN, we have a family counselor that's on duty on all the days that we have these services, and it's for improving and enhancing the mental health, as well as we've been collaborating with Judge Mack to improve AOT services. He actually did give us one of his presentations.
Yeah.
But I'm pretty sure everybody is familiar with the laws. And it's to reduce the recidivism, crime, substance use, and homelessness for adults with SMI, and to strengthen the social behavior health function among adults. As I mentioned, our peer and family recovery coaches, this is one-on-one services. So it's not that there's going to be a group of individuals. They have a gym to work out. We work with them on the gym. We work with them in holistic, and we have AccuDetox. What else do we have that helps them out, Lisa?
Well, with the health and wellness, we have meditation and grounding exercises to promote the self and body awareness and sensory connection, and finding like the holistic balance. That's health and wellness. You kind of skipped over with the peer, but the health and wellness coordinator is actually also a mental health peer too. So they do receive the same kind of peer-to-peer services with her.
You want to talk about your case
So,
management?
yeah, I am the nurse case manager, and my duties include the follow-up assessments. So 1 to 3 times a week. The program is Monday, Wednesday, Friday. It's just depending on their availability. You know, we work to get them a job, so that kind of interferes with some of the scheduling, but we work around that the best that we can to keep them involved and engaged. So anywhere from 1 to 3 times a week. And then I also help to reinforce the medication teaching, because a lot of the noncompliance comes with a lack of education. And then the collaboration with, if they have a community mental health caseworker, therapist, psychiatrist, anything that's part of their mental health treatment. So involves a collaboration effort.
So this is just another layer to help an individual where, their mental illness, so that they're a little more grounded and having more one-on-one personal support. And it's just another layer. We're not taking away anything from their, mental classes, education, their psychiatrists. We're just adding to it. We're just enhancing. And it's of no cost to them, but the only issue we're having is it must be on an AOT referral for the SAMHSA federal grant. So we've been working with individuals since, when was our first client? It's been 5 weeks. And we have some examples of how it's working for us. We do have a couple AOTs, and as well that we have Charles Owens here. He owns an SMI house in Fraser. So he's been having a lot of his clients, but we're running into issues where we can't work with them because some of the case managers don't believe that it's necessary.
Well, one of the issues is either that they don't feel that they qualify for AOT, right, when there's a lot of evidence to kind of back up why it would be appropriate for them to be on the order, and a lot of times in those cases we'll still work with the individual because they'll benefit from our services. It's just the issue, like she said, it doesn't count towards our grant statistics to be able to help keep this program up and running.
And some of it is they're not educated on what we're actually doing. And so that's what we're trying to do, is get out there a little bit more and educate them on just having a peer with you. And as we know that peer recovery coaches and family coaches help an individual a little more than being in a clinical position, but we're working with them one-on-one, and just giving them another layer of support and help, which has been miraculous with the several cases that we have already done. If you want to tell them some examples.
Yes, I provided a couple case examples, and the first one, this is a client that has bipolar, SUD, non-compliance with medication, active substance use, domestic conflicts, so poor communication and follow-up with their caseworker. And initially, so with the, when she first came to our program, you know, I kind of stepped in to try to advocate for her to get her in with her her follow-up appointments, which she, you know, didn't really have. She didn't know when they were or who to contact, or, you know, didn't want to put the effort in probably to figure those things out. And I was able to connect with her case manager and report all of the findings. So she started demonstrating signs of mania, and she was overdue for her her injection that she was getting monthly for psychosis. And she, so fast forward now, she's been with us for 4 weeks, and she is compliant with her medication, she has 3 weeks of sobriety, resolved domestic issues, improved focus, and actively participates in the program, and has increased self-sufficiency. So she has verbalized that she actually does enjoy coming to the program, and kind of gives her sense of purpose and wanting to see herself do better. And then, so case number 2 is, this is a client with schizophrenia, substance use. He was hospitalized 3 times in 2 months, and this is another example of the AOT, that he should be on AOT, just for the reason that 3 times in 2 months, due to his non-compliance with medication. So he's doing well when he's in the hospital and they release him home, but then he decides to stop taking his medication. So right away, he was only with us for 1 week before he was re-hospitalized and relapsed, but an issue we ran into was that he was in Wayne County, so he didn't have any connection with his caseworker. And he moved over to Macomb County and didn't have, you know, any plans to return back there. So we had to try to help him get everything switched over to Macomb County. Meanwhile, I had no information as to who his doctor was to call and tell him when I found out he wasn't taking his medication, and it was due to the side effects. So, you know, there's just some roadblocks that we hit because we're not part of, you know, the community mental health, even if it was part in Macomb County, because sometimes they will deny, you know, the information because we're not part of the contract. So so like I said, he was hospitalized within a week, and he did come back. He actually was just discharged this week from the hospital, but again, not on AOT. So he wanted to come back. He said, you know, again, it helped him with his purpose, and he enjoys coming, and he enjoys like the one-on-one, and he feels that it is benefiting him in his recovery.
And none of these clients wanted to be there in the beginning. So it's, you know, we're just doing one-on-one, whatever it takes. You know, we'll go there and pick them up. We have transportation, we'll go to their home. We have 2 individuals that will go, a peer recovery coach, so they have somebody talking to them the entire time, that they're picked up from their home and dropped back off. They have lunches, snacks. They're able to roam around the resource center and, you know, get involved as well. You have one more?
Yeah, the third one is bipolar SUD client. Same thing, medication non-compliance and lack of understanding. She reported to us on her hospital discharge that she had delayed follow-up appointments. I want to say this was 5 or 6 weeks out, but there was no way for me to confirm or call a doctor for her. She didn't give me any of the information to be able to connect with that, and so I tried to call the, I had a number for the caseworker, but they wouldn't give me any information because I wasn't, on contract. So she ended up rehospitalized and relapsing, and yeah. So again, those are the biggest barriers that we're running into, and this challenge is, not necessarily up to us to decide who is going to be on AOT, but we do know that there are a lot of clients that the courts have already ordered, and so what we're actually trying to do with CMH is to connect and build the relationship there where they can contact us with the court order so that we can help contact and monitor them a little bit closer for them in between their appointments and help improve the services that are ordered. So that's AOT.
So we also have other grants that we're working with SAMHSA, which is a peer, that's the family coaching, job staffing, education, and vocational, as well as the family. So it's both family support and peer support. As well, with our resource center, we've put in your backpacks and in your shopping bags. So we put all of our information in there as well. Our resource center is located, I don't know how many have been there yet. I know Lori has. And Selena, a few of them have come to our tours for them, open houses. But the Resource Center is located at 11.5 in Gratiot. It is 14,000 square feet. We have events all day long and through the evening. When the front office is closed, the back office is open. So we have a music didactics, we have a gym, we have a library, we have yoga, we have trauma-informed yoga, we have health and wellness, mindfulness. We have 2 groups tonight called Pink Cloud, and these are all open to the public thanks to Macosa helping us out there as well. We have individuals that will be there for peer one-on-ones. We have family coaching, we have LGBTQ, we have art recovery. So there's things for individuals to do, as well as be a food pantry, clothing boutique, and we have RCTs that are working with individuals the minute they walk in the door, transportation as well. We do monthly events, we do legal assistance, where we have attorneys come in. We recently did expungement fair. Jody Switowski ran that for us. And we do vocational training. We've done real estate classes where we'll pay for the individual. So there's a lot of things that we do, as well as PRC, peer recovery coach training. And we're just wanting to utilize and maybe help. This grant for AOT is all of Southeast Michigan, but we're here in Macomb County, and we would like to be able to utilize these funds here in Macomb County and just give another layer of support to the services and to the individuals that need it. Does anybody have any questions for us?
I understand that somebody at CMH has to authorize this AOT in some cases that's not happening. What do you think is the barrier? I heard you say technical assistance or some training, but
So in the cases that you're referring to, where they met the criteria for AOT, but the caseworker didn't feel that they were appropriate. So the one in particular, at first it was on board for it when we explained the program, and what's that?
We call the supervisor.
Yeah, actually Charles was in on this because if you want to.
Why don't you elaborate for that? Here, you want to stand over here, Charles?
Sure. Just when we get to the point of talking to the case manager and then the case manager is very excited about it and said, well, I have to report it to the supervisor. And once the supervisor receives the information, it comes back to us saying that they turn us down. And I don't know if it's because we don't have a contract with them but that's the barrier that's going on right there.
Well, and what they said was they didn't feel that she was severe enough for AOT, but the AOT is really, it's supposed to be preventative, you know, so when we started to see the decline and she was showing all the signs that she was going down that path, it was like we wanted to step in and do something. So fortunately, this was the case that I was able to get her, you know, set up with her appointment to get the shot, and that really did help kind of put everything else back in balance. But, and you know, I'm not to pat ourselves on the back, but we put in a lot of the footwork to get there, and then they're saying she doesn't need AOT, but she really wasn't going to do any of this herself. She needed the push, she needed the help, and we want to help her, and we are. We're still seeing her 2 to 3 times a week, but she's not on an AOT order. Today, if you looked at her case, she wouldn't be appropriate for it because she is doing a whole lot better. But at the time that it was requested and it was like to try to get her into our program, it was denied. So, you know, fortunately we were able to still provide her the services, but there's a lot of other cases similar to this, and without other funding, you know, this comes right from the grant, and so the funds are supposed to go towards clients with AOT orders.
So for staff, Adam or staff, what's the funding source to us that would be a problem for us to authorize it?
I have to admit, I'm not familiar with the program or some of the barriers or the issues, so I really can't speak to it. I'm sorry.
So there is no cost to community mental health?
I think it came down to having a contract to be able to share the information, although speaking with Judge Mack, he, you know, he kind of agreed that the HIPAA laws don't prevent sharing of information because it is still a continuum of care in this case. So that was something that came up as a barrier as to why community mental health wouldn't freely like send over information on AOT orders.
Selena?
Okay, so an AOT is a court order for treatment. CMH isn't responsible for any type of payment that goes with it. What most of the AOTs are coming out of are your hospitals. Mm-hmm. They're initiating them because the patient has come in 3, 4, 5 times for the exact same thing, not taking their meds, decompensating, not following up. So I think that if you really want this program to be very successful, you need to connect with your inpatient, your emergency rooms, where they are initiating AOTs for the fact on behalf of the CMHs, where they are actually seeing the type of patients that you're doing it. And so I think that you're missing an opportunity. The health system I work with, I probably on a week out of all 17 in my hospitals are probably doing a good 20 to 30 AOT recommendations based on the fact that maybe the patients have hit my emergency department 4 times in the last month. That tells me that something is going on with them and they need a little bit more support. I don't recommend AOTs for anybody just because maybe they missed a dose or times are hard or anything like that. This is a court-ordered treatment. This is a legal requirement that I get to pull the plug on that patient at any time that I think I can. And I don't think that not everybody needs that. Sometimes they just need the guidance that goes with it. So I think that maybe if you guys looked at another means, I think what you're doing is great. I love your organization. I refer to you all the time. Out of my one hospital, but I think that that's where you're going to be able to pick up a lot of folks that can't wait 3 weeks until they see their next provider. And that 3 weeks is such a critical period of time where if we had somewhere that we could send them and they're like on that AOT, and we can send them that you can keep them safe day by day by day until they can get to that next appointment, we're going to see compliance and we're going to see success.
Thank you.
Yeah, so to that, we've actually, that was the first place we started, because it was one of the first recommendations. But an issue that we ran into and continue to, in one of the cases, as I explained, that he was hospitalized twice in 3 months, and this is the case for everyone that we get referrals for that's coming out of the hospital and they have this history. What they're saying is, even if they're petitioned in with the combination order, they're deferring AOT.
So it's no longer an AOT order.
So, and they're a lot.
So they have a right. We have to offer that, according
Yes.
to the mental health code. We have to offer them the right to defer. We
Yes.
have to offer them the right for a trial. We have to offer them those rights. Now, if a psychiatrist comes in and says that this patient isn't competent, they can't make the safe decisions, you know, they're coming in, they keep deferring 3 days later, then we can go to court on behalf of that patient because they're not able to. But we have to have really good, sound decisions why. So a lot of times, you're right, a patient can, they often defer. We got to really, and I'm working with Judge Burton and Judge Mack on this whole thing that you guys are talking about. I was just with them this afternoon. You know, to help educate and to understand that the AOTs are to help guide them when they can't make those competent decisions, and that allowing a patient to defer 2 or 3 times in a month or 2 months, that tells you right there is the reasons why they need it. So
Right.
I think that we have a lot of education that needs to go with it. Don't give up. It's getting better. We're really kind of seeing that it needs to be done. But this is going to be a partnership with your CMHs and with the hospitals, so that, you know, when we have a patient and we're calling in and we're trying to get that authorization, we're going to have those conversations with our CMH partners to say, what is the aftercare plan? What is going on? And the education to the CMH case managers are going to be, look, the patient is being non-compliant. She's not taking her medicine. She's not spending her money wisely. She's, you know, transient in the community. She's couch surfing. This is the patient that we need that AOT on. We're going to, you know, and that would be part of their plan to us in the hospitals, is that, okay, this is what we need to put on this patient. This is what's going to be the best thing for them. So I think that we have to really, you know, bridge those gaps for you guys. But, you know, I think that you guys have something that it can be very successful. You're going to be that bridge to keep them from falling apart when they're between appointments.
Well, we did have a case where she was really severe, and she was in and out of the hospital consistently. So we filed a petition, and the court called me back and said that, and she was really severe, you know, and so they said that they could not give her ALT without CMH. They told us that we need a referral from CMH. So when we contacted CMH, that's when the barrier right there. They would not give us that referral. The case manager refused. She went to the supervisor, and the case manager was willing to do it, but he said you have to talk to the supervisor, and when the word came back to us, it was a no. So
That's unfortunate.
And that's the same thing that happens when we petition an individual for AOT. They told us that at the probate court, said that they could not petition without CMH.
Well, yeah, I think they were confused because we did clarify with Judge Mack that wasn't
That
true.
shouldn't
but-
have been the
but
case.
Their understanding at probate court was that the CMH caseworker is the one that does all of the AOTs, or 99% of them, so.
And even though that the supervisor refused to give a referral, Brenda still allowed the client to come to the AOT program. And so she's in compliance now, awesome, and she's back on her meds. And even though that she was refused from CMH, she's still getting service from Live Right.
I'm not real sure about why CMH has to do a referral, so
Yeah.
I guess, I'd have to look into that a little bit more. I'm not understanding that piece. Nick, maybe you know.
Nick?
Yeah, because that doesn't really make a lot of sense to me. If you petition a person for treatment, the normal petition route would be for hospitalization, and that doesn't require our consent. The probate court makes that decision, and then it goes from there. For outpatient treatment, I don't think there's a provision, and you've indicated that Judge Mack, who's pretty knowledgeable about these things, doesn't think so either. Have you worked with anybody in the Macomb County Probate Court?
That's who that was.
That's who that was. That's who was telling us we had to go with CMH. Helen was with us on a couple of our Zoom meetings with Community Mental Health, and she kind of has a better understanding. Could you tell us your part about the Community Mental Health, what you... She actually was explaining about their, the contract with...
Before you go to that, let me clear up something else in my mind. Do you deal only, it sounds like you don't, but your grant deals only with court-ordered alternative outpatient treatment programs, but you also deal with voluntary treatment? Because that's one of the things Selena was talking about, I think, that, if I'm going to petition somebody for hospitalization for anything, if they voluntarily comply to treatment, you don't go through the petition process. Do you provide services to people who voluntarily accept treatment, or only for court-ordered treatment?
It's for court-ordered, involuntary supportive services. It's not treatment, it's supportive services.
Well, it's alternative outpatient therapy.
Right.
Is what AOT stands for. So I'm sorry, therapy is a broader term than treatment. You're absolutely right. It includes and supports and services. But I'm trying to figure out from your presentation, you indicated that you were also providing services to people who were, although it wasn't covered by your grant.
At the time we are.
Yeah,
Well, because we have the staff and we're like ready and able to serve, so, we're not gonna turn people away that need the help. But as we're trying to grow and like I said,
But you don't receive, you can't draw down your grant for
No.
that, so you're essentially doing that for
Just-
free, and that becomes obviously a problem after a while, I understand that.
Right.
But I guess I am confused, and maybe staff can check into it, or maybe Helen knows that why the probate court is saying they don't have authority to act without our okay, because that, rarely do I hear courts say they don't have authority to act without somebody else's okay.
yeah, I think she was.
Can you help us clarify?
I can't speak to the court, no. What I did was, Brenda's program works with us for recovery housing, and they've been a great partner for that, and they also have the recovery center. That was one of the recovery centers, along with the Care Recovery United that we use. And so she presented her information about the SAMHSA grant. Now, in community mental health, we're very familiar with AOT because we have staffing that works with that and works with the court and makes sure that people are following up on those outpatient services. So at first, there was a communication gap between Live Right and CMH because AOT, they think, we know that to be treatment. And so we really had to get using our language correctly because even the brochures at first were a little confusing that we saw. So we really worked to say, okay, Brenda's program, Live Right's program, is not treatment. It's the supportive services, it's the peer services, it's all those other recovery type supports that you get from her center. It's not treatment. So with our mental health clients that are already under CMH, under the order, it would be a supportive service in addition to what they're already getting, because they are not going to provide the psychiatric services, they're not going to provide the case management like a CMH worker would. So they're parallel and conjunctive kind of services that can go together. I think at the time Brenda mentioned to me that one of the problems that they were having is they have to also be written on the order. So CMH gets written onto the order, and I don't know if this has changed, but when we had our meeting, that was part of the concern was the courts will order the client to participate with community mental health services for outpatient care. But then it's not also ordering them to also work with these peers and these supportive services.
Yeah, that
Judge Mack did
So,
explain that
that
we
was the
don't need
original
our
issue.
name on it, but they need AOT from our
They
services.
have to just have the order.
We just need them with the order, so that helps.
Yeah,
We're gonna-
I'm
we're
getting
gonna record-
closer.
We're going to record Helen
So-
so that we have that explanation.
I'm getting closer to understanding this, but Ellen,
Follow up with CMH.
Yep.
But nowhere does it say that you are the supportive service that goes with it. So CMH would have to add you under
Yeah.
their
Yes.
umbrella
Yes.
so that they follow the court order through them, or they need to specifically add you to the court order as the supportive services. So now I get it.
That's where the rub has come in.
That is where.
And,
Yes.
yeah, and it's not that CMH won't share information, they do have to have a release. And that's part of probably what you've run into at times when you want to coordinate care with CMH. They're not like a physician's office who can just, share information because it's in the client's best interest. There's a higher level, so they do have to have that consent sign that says specifically they can speak to Live Right Corp. To coordinate care and services and work together.
unless the court orders it.
Even with the court order, CMH still needs a release to share information with another provider, even with the court order.
Even if we're on the order? Just curious.
The individual still needs to sign the release, because a court can order you to do anything, but it doesn't mean a program can provide information and break HIPAA or break 42 CFR confidentiality rules. The court can order the individual to something, but not the agency.
Order them to sign that release?
They usually do.
Okay.
Yeah, they usually do. Because they know that. They know that, I can't get them somewhere if they don't communicate.
I guess my concern here is, how does that then communicate through the rest of the staff? So if a staff person comes back and says they need these supports and services, and they're on an order for alternative outpatient services, and we don't have that service to offer, but they do, and they've got a grant to cover it, and we want to refer them down, don't we then try to get them to sign or ask them to sign the release and send them over? Or do we just say no? Or?
CMH can definitely use this program as a referral source, in addition to why they're providing services, just like we do with lots of other partners in our
So if
community.
you refer them over, then they would be asking the patient for a release, so you could
CMH
communicate
could, as
with
they
each
make the
other.
referral. So if I'm a consumer under CMH and my therapist wants me to also work with this program and I agree, then CMH will ask me to sign that release, and then they can share their communications.
Because I'm concerned about how, just as one other question, if I may, then I'll stop. The techniques that you use to deal with people who are non-medicine compliant. I know you got all sorts of problems because you're also dealing with patients, right? So you've got to kind of balance between pushing them to take meds and pushing them not to take substances that are harmful. But what sorts of techniques do you use to keep people compliant? Because non-compliance is one of the major reasons we end up with rehospitalization.
Right. Well, we do have wellness and mindful, they're clinics where they're working one-on-one with them for the yoga, the mindfulness, DBT. There's also a grounding clinic that makes them feel okay when they're on their medications, and they can discuss that with Lisa as well, what the difference is that they're feeling from their medications, and we're trying to get them comfortable in their own skin while they're on those medications. And that's where the one-on-one comes in, and this is a whole different team that is working with them. We've had training with mental illness, safety first, craft training. So we've been doing a lot of training to work with the individuals one-on-one.
And also just the peer, I think, too, kind of helps, because a lot of the clients have first reported to the peer that they're having these issues, and they feel more comfortable talking to the peer to say, I'm not taking my medication. Or, I don't feel like myself on it. I feel okay without it. And to me, they'll tell me, something different or half the truth. And so that's where we kind of get into, they'll open up a little bit more, and And then also being able to see them or talk to them, knowing, we'll call and make sure they got their medications. Did you take it? Sometimes they need like the reminder if they just absolutely don't want to. That's not going to help. But I feel like that has been one of the biggest assets is having the peer, because they don't feel like it's the doctor who doesn't, listen to what they're saying or, think that they know what they're talking about with their own body kind of situation. And that's what they reported.
What kind of
More that
success?
comfortability, feel comfortable,
Sure.
right? They feel relaxed, just that one-on-one.
And what kind of success have you had with
Since
getting
May,
compliance?
May 30th, we have 3 or 4 clients that have they're successful, they're still showing up,
And compliant,
And compliant.
and have some clean time from not going to the hospital, meaning clean
Right.
time.
Yeah, so.
Very good. Thank you.
Thank you.
Megan?
Thank you. I just wanted to know if we would be able to stop by the facility and maybe tour it?
Absolutely, we'd love to have you.
Wonderful. Is it like a drop-in, or would you prefer us to like
Depend-
schedule?
You can drop in, or there's a group of you that would like to come, just
Okay.
let us know and we can set it up and take you on a tour.
We like tours.
Okay, good. We'll do the tours.
Thank
Lori?
I was fortunate enough, when our van was there, or is that what we call it, our van? I did go, and I was fortunate enough that I did receive a tour from Brenda and Lisa. And I was really blown away. And I've also been on social media following them all the time and sharing information, is that they involve the families. They involve the kids. It's not, in trying to keep that family unit together, which I think was so important. What they're set up with their pantry, the store that people could come in and get clothing, whether it's to go for a job or interview or something. They have it all right there in those support systems. And I just think I was a lot of stairs, but no, I think I was very impressed with the hour and a half that I was there and everything that they do.
We love tours, so.
That's true, we do love tours.
We are setting up a presentation and tour for a lot of providers in October, early October, because we have like some of our large events coming up here. But I'll reach out, or however we set this up. My assistant's not here, and I think Dana, I told you I would email you some things, and we would love to have you, really.
Thank you.
Thank you. Any other comments from the board?
Thank
No?
you, Brenda.
Thank you.
Thank you.
COO update.
Yep. Thank you for the time here. Just want to give you a quick update on our annual initiative, as I mentioned earlier, with the strategic plan and then some of our initiatives for the upcoming year. We did have 5 initiatives that we worked on throughout the year, and we achieved 3 of them. 2 of them we continued on for the next year. The first one was to create the customer service and call center, which we did achieve. We were able to hire a dedicated call center administrator. We created some call center processes and protocols, and we created and monitored some customer service metrics. So one of the questions on the customer service issue was, are they answering the calls? Are they answering them quickly and professionally? And we were able to put in the metrics to show that we have been greatly improving in answering those calls. There's a lower drop rate, which is people who are waiting on hold, so then they decide to terminate the call. And we have also been doing some blind call monitoring to assure that they are following the protocols and they're being professional and helpful on the phone. So this is, even though we completed it, we're continuing to grow, continue to expand. I think we're up to 7 or 8 staff right now on the call center, and we're looking to expand into weekend hours and looking at some greater coverage overnight. So that was a good project for the year. We also had the initiative to create the new accreditation standards for NCQA. And then we've talked here about hiring the NCQA consultant, which is in place, that the board has approved. In the NCQA Phase 1, not only did we want to hire the consultant, but we wanted to explore the HEDIS measures, which will help us to obtain NCQA accreditation. Also to design and develop and implement some of the policies and procedures that will help us to obtain this. We have started. We have a policy administrator at MCCMH now who's helping us to review our policies and update those. And when we have our consultant come through and get the feedback, we'll close the loop on the policies and procedures that we need for the accreditation. So we achieved this by starting it, and now our step 2 is to get the accreditation. So we'll keep you updated as we go there. We also had an initiative under CCBHC for the contractual and regulatory standards. Some of the goals in here were to meet the requirements of the grant, one of those being the growth. We met the 1,500 person goal, and we're continuing to grow. I think we're at, Agnes, what are we at about?
Around 1,700 something.
Yeah, so we're getting close to 2/3 of our goal. So we're moving forward, we've showed some pretty big improvement in a short period of time last fall, and then it's been pretty steady since then. And this is an area that we're monitoring on a weekly basis to assure that we're continuing to meet our CCBHC numbers. We also established one community partnership, which was with Alabaster Gift, thank you. I don't know why I was blanking on that one. So this is one of the community partners. They work with victims of human trafficking. So we were able to develop an MOU, and we're working at a referral process for them right now. We're also going through the state of Michigan, the demonstration certification right now. A lot of work being done with our team, and it's moving along quickly, but we hope to have some good progress reported for you soon. Our next initiative was on data reliability. This was to assess the current state of our data and to look at our data systems. This one we did continue. You can imagine it was a huge undertaking, but we did have a couple of good steps this year. We had an old data system that we used to use called Crystal Reports. We did end the use of Crystal Reports, and now we're fully into PCE and with our Afia partners. We also hired our in-house staff, who I mentioned, Rachel. She is our Director of Clinical Informatics. So she is helping us to design our overall data plan for MCCMH. So she started not too long ago, but making some good progress in that area. That's one of our upcoming initiatives in data. And then lastly, for this past year, we worked to develop and implement a team member engagement process. This was headed by Tracy Smith. We had some successes with creating the team member handbook, creating the supervisory training directly focused on onboarding, placed the orientation on our learning management system. We created accessible org charts and implemented regular team engagement building activities. The thing that we're continuing into this upcoming year is part of it is to ensure that all the team members sign off on their job descriptions, which we integrated our core values on. So just a few updates in that area. Our goals for the upcoming year, we are going to be designing and implementing residential system improvements. This is one that I'm heading up, and it is going to be, we know the issues with residential and with the staffing, so we're really putting a lot of resources to helping to design some solutions, including just looking at some of our benchmarks and determining how long does it take for someone to get into a residential. What is our true measure of beds that we need within Macomb? How are we doing in the Tri-County area with that? So one area we're covering. We are also looking at the emergency residential needs and creating some options for that. We want to implement a residential report card, which would be looking at all our residential providers and how they do a real good apples-to-apples comparison, and include things in there like how quickly they can bring someone in, how many people they serve, what type of individual will they accept. Will they accept someone with high behaviors, with medical needs? Are they a barrier-free facility? So we just want to get a better measure of all of our providers across the board and how they do with our people. We also, in this upcoming year, we want to improve the access to care. We want to improve our penetration rate, which is, I believe, about 4.6%. Our goal is to improve that to 6.5%. We want to identify some root causes for our low penetration rate and develop some and implement some plans for improving that. We also want to create and implement some marketing messages. What's interesting is now that we've been monitoring the phone dashboards and the call center, we see that our calls coming in the front door are relatively stable. They don't go much above 5,000. They don't go much below 4,000. So we think it's interesting that with the continued needs that are in the community, we're not getting more calls. So we want to look at some more advertising to get the word out there and to get more people calling, get more people through our front door. We are also going to improve our member satisfaction. Within that, we want to establish a baseline for the current members, the current state of member satisfaction, identify and implement additional methods for gaining input and for measuring satisfaction, and develop a process for how following up and handling concerns. You all have approved the Happy or Not system, which we have in place, which is getting us some good data. We just want to assure that it is capturing everything we need, and are there other ways that we can be capturing the satisfaction of the people that we serve. We are also going to be working on building a culture of staff engagement. This is a follow-up to the one which I mentioned a little earlier. Within staff engagement, we want resources created for supervisors and trained in best practice on providing supervision. We want to ensure that written evaluations are in place for all classifications, implement engagement activities and process checks to measure effectiveness of those engagement activities, implement management measures and dashboards that can be utilized by supervisors. We do have some dashboards available in our focus system where we'll be able to see how people are doing with their documentation, for example. But we want to expand that and make sure that we are able to give the supervisors the tools to really monitor how their team is doing. And then lastly, we want to optimize our data systems. This is the continuation of the data project from last year. We want to create a new detailed work plan for Afia. We have some overarching goals with Afia, but we want it to be real tight and very detailed. This is an area that Rachel's focusing on. We want to ensure also that any projects that get to them have been vetted, that they are necessary within the organization, and they fit within the scope of what we're looking for, and that's something that we can't do in-house. Like, the only thing that should be going to them is something that we really cannot handle at this point. We also want to review and edit our performance improvement committee. We've got a really great committee that meets every week, has some really smart people at the table. We just want to make sure they're really focused in on what they need to do to improve data within the organization. So big push of ours this year. And we want to ensure that all dashboard data is accurate and valid. This should be the duh moment of the day, but really we want to prove that the data that we have is good data. And that's a little bit more challenging than you'd think, so we're going to work to make sure that it is the stuff going in and stuff coming out is all good information. And then lastly, we want to implement a real-time dashboard for the penetration rate. This piggybacks on our access to care. In order to improve this, one thing we have to do is make sure we know on a running basis what our penetration rate is at. One challenge we've had previously is the penetration rate number comes to us from the state and it's 3 months late, which is fantastic, but unless you know on currently how you're doing, you can't adjust, you can't do anything different. So we want a better current measure of what that rate is. So work has started. The groups are meeting now to move forward with these initiatives. All of our 90-day rocks is what we call them, but a 90-day work group, they're all in alignment with the annual initiatives just to keep that momentum going. So a lot of work being done. We had some good successes last year and looking forward to reporting more success next year. And I'd be happy to answer any questions about that.
Thank you, Adam. Any questions from any board members? None? I have one question. And you mentioned last year the customer service, the call center.
Yep.
I don't remember, time has flown by so fast, but you and Dave presented us those statistics on how many terminated calls, and we as a board were like, well, how can we get these decreased? And you just said that we have gone down.
Yep.
Could you provide us with some more data on,
I can.
on like what the progress is on that?
Yeah, absolutely. And what I'll do is I'll get some of that together for the full board.
Okay.
And be able to present it to you. And just a couple ones that stick out on the top of my head. So for the dropped calls, it's called abandonment rate. We set our goal at 5%
That's right.
Under 5%, that's a national average. And I think for the last 2 months, we were under that 5%, and we're trending under 5% now for the call center. So yeah, that's just one small area. Another one is the service level, so that's the amount of calls answered within 30 seconds. We set our goal at 90%, and the last 3 months, I think we were at 83, 82, 87. So we were showing some good increases in there. But I'll get some.
What about
some of
the average answer time? I remember that was another.
Yeah, the average speed to answer?
Yes.
Yeah, I don't remember that one off the top of my head, but I'll put that one in there as well.
Perfect, thank you. Any other questions or comments? None? Okay. Thank you, Adam.
You're welcome.
Just a reminder that our next meeting, the full board meeting, is on September 22nd at 6 o'clock. Finally, hearing of the public. Is there anyone from the public looking to address this board? Seeing none. Number 10, is there a motion to adjourn? Oh, of course. Donna?
3 days from now, it's going to be the 20th anniversary of September 11th. And I've been watching some of the specials that have been on television, and it's bringing up a lot of emotions from 20 years ago. And, we're a mental health board, and I think that a lot of people are going to be going through, some mental health stress from 20 years ago. And so, as a mental health board, I think that, we should keep those who have lost people 20 years ago in our thoughts, and also the public will be under a lot of mental health stress in the next week, in the couple weeks, because of the 20th anniversary. So we should be thinking of them and really reaching out to them, reaching out to our friends and our colleagues, and thinking of them and calling them and offering our support, because I think it's a really stressful time. I know myself, even watching, the reactment of it has really affected me. I've been watching it, and it's affecting me more than what I think it is. So I think reaching out to our friends and our colleagues is a really good idea at this time. And I would encourage everybody to be doing that now, because I think it's really a stressful time for people. So I want everybody to think of your friends and your colleagues, your parents and your friends, and reach out to them during this time, because I think it's a really, it's a tough time for people. So I would encourage you to do that. Thank you.
Thank you, Donna. That's been on everyone's mind, I think, the last few weeks, especially with everything that we've seen in Afghanistan, and all the people that have served over the last 20 years in the war on terror, and all the sacrifices many people have made. So thank you. Any other comments from anyone? Hearing none, motion for adjournment's in order. All right, all in favor signify by saying aye. We are adjourned.